Indians across the globe. We are celebrating 79th Independence Day of India. Also, good morning, good afternoon, and good evening to all the viewers of the Vertebral Views, the OrthoTV Spine TV Global Spine live stream show. Today, have Dr. Andrea Lebel. She is one of the topmost physiotherapists in Canada and the world. She has more than 40 years of experience in treating patients. She has treated thousands and thousands of the patients, also has trained more than hundreds of the professionals. She is consultant physiotherapist at Ottawa Clinic in Ontario, Canada, and she was the president of the Scoliosis Physiotherapy Schroth Protocol Society too. And she'll be teaching us today on scoliosis under control, bracing therapy and innovation in managing early onset scoliosis and adults and idiopathic scoliosis. We are very lucky and fortunate to have such a distinguished guest in our show. It's all over to you, Andrea.
Thank you very much for your invitation to present on my favorite topic, scoliosis-specific physiotherapy and awareness and screening and treatment. And I appreciate all the professionals tuning in. Happy to answer the questions afterwards. So I'm in Canada, and I have been certified in many type of scoliosis-specific physiotherapy methods, as well as I have been very busy raising awareness, bringing the patients together, raising funds for local hospital, as well as presenting around the world on the topic of awareness of scoliosis and early detection. I'm in Ottawa, Canada, and this is where I treat my patients. I also involved with international education of professionals of scoliosis-based topics and latest research on the scoliosis and spine online learning with my colleague, Dr. Hagit Berdyshevsky. And you're welcome to visit us for free education around the world. First, I would like to start with this very important statement from Dr. Boachi, who was the SRS president in 2009, and he's very supportive of the Schroth method physiotherapy. Out of 10 patients coming to my office, as he said, I only want to do surgery on one, and the other 9 I will refer to you for physical therapy and bracing. He stated that in 2009 at the International SOSOT Conference in Lyon, France. So today I'm going to talk about the 90% of the patients who are not needing surgery or not electing the surgery and will be referred to conservative management of scoliosis. As you see, early detection is key to avoid the severe deformity. Childhood scoliosis is progressing silently, and many leading societies are warning and promoting and asking to establish screening methods in your community. Scoliosis being a three-dimensional, very progressive in growing children, adolescents and children, deformity, and multifactorial. And according to Carl Auburn, is deformity of not just the spine, but the trunk, involving vertebral wedging, extension of the spine, rotation and lateral wedging, and rotation of the disc and vertebra together, and can be structural and functional. 80% of the cases are idiopathic. These are cases which are not known of the origin. And scoliosis can be screened clinically by having the individual perform the Adam forward bending test, which we're all familiar with. And this test should be afterwards followed up with radiograph. So these are patients with idiopathic scoliosis. Potentially out of 100 children, we will have 3 to 5 diagnosed. 1 to 3 will go for bracing and optional physiotherapy and surgery. 1 will progress to the magnitude of surgical indication. 8 times more girls are affected than boys. So I'm urging you to figure out which girl here has scoliosis or going to need your medical attention. And it is a surprise diagnosis for most families when the children are diagnosed with scoliosis. They're doing sports and activities, they're healthy children, and one day from the next, if they're not diagnosed on time, spinal surgery will be recommended for advanced curvatures. So it's very important to screen out the visible signs of scoliosis, not just the common one with the shoulder uneven and the rib cage uneven, but also looking at the rib hump, the rotational component of the scoliosis, which we are not very keen to measure or look at it very often. And this is the test for the Adam forward bending test, and this is the handout which we see most often. And this, I just want to show you, it's already a very progressed, very severe early onset scoliosis with a lot of rotation and a large rib and torso deformity. So we have to screen out the children with very, very mild symptoms if we want to treat them on time. And these days, it's very easy to do this test. You can use your smartphone and all kinds of applications to screen out scoliosis. That will be the first very important step. Teach screening in your community. Have everyone screening these children because late diagnosis is very common. And once the progression already advanced, it's very unlikely that the curve could be halted before surgery. So this is community center education. You can have application or use the original scoliometer, which is intended for the screening. And if this measurement reaches 7 degrees, an X-ray will be recommended because there will be most likely a scoliosis. In Canada, we have 32% or even higher since COVID have late diagnosis. We do not screen in schools here. And when the children come to our office, they already have surgical range. So this is also a slide in Ghana in terms of scoliosis screening happening and early diagnosis of scoliosis. And these days, with great technology, we can use our phones, many applications to screen out scoliosis. And the latest advancement in Momentum Health is FDA approved, a 3D scanner, which can monitor any type of progression of the patient's posture and give an AI representation of the trunk deformity and the estimated cup angle. So school screening-based programs work, and it will be the way to screen out scoliosis either at the family involvement or the school involvement. And there's a big question, screen or not to screen, because once we screen, we do find the children who have smaller curves, and not all of them will be progressing. But once they have an important curve, an important angle of trunk rotation, and past 7 degrees, we need to confirm the curvature with a PA X-ray, standing X-ray. And we measure the cup angles, more than 10 degrees, we call it scoliosis. So why do we need to screen? We need to provide the least invasive treatment and in time for the patients. Once we have that screening program established, we can have the children have many other treatment options, not just spinal fusion surgery. So early detection allows them to have part-time or full-time bracing, scoliosis-specific physiotherapy, and potentially preventing curve progression or reduce the speed of the curve progression with these treatments. Also, if it's treated early, then reduction of brace prescription and potentially the needing of the surgical intervention. And again, many societies are promoting or at least recognizing the physiotherapeutic scoliosis-specific exercises and the bracing and the importance of this intervention. Combined or bracing alone can decrease the likelihood of curve progression to the point of requiring surgical treatment. And this is how an ideal treatment would look like when the surgical intervention could be avoided. So this is a late diagnosis of an 11-year-old who had the adolescent idiopathic scoliosis diagnosis. It might be also developed a little bit earlier, could be an early onset, but nevertheless, it's a 48 cup degree. Surgery was recommended at that time, spinal fusion selective surgery, and instead the patient started full-time bracing and Schroth physiotherapy. Reduced the cup angle below the surgical indications, and you can look at the improved aesthetic, the improved postural balance as a result of the intervention in the treatment. And we're looking at very large risk of progression. Risk of progression in this age group, juvenile, early onset, and adolescence, is really fast during growth. And 8 times more girls are affected than boys. Curve magnitude 25 cup degrees, 30 cup degrees are usually progressive, and growth potential is huge. You can see this little child here who has a very tall father, and he has to grow a lot to reach that height, and the curve progression and the risk of progression is very high during growth. And during adolescent growth spurt, whether you're looking at the Reaser 1, 2, 3 or the Sanders 7, 8 below, there are high risk of progressions. Other charts, Namason and Lowenstein also produced a great indication of curve progression based on the age and curve magnitude. And we have also Duval-Beaupre curves progression, indicating the fast progression between ages of 11 and 15 for this adolescent population. But we also have the brace calculator now available free online, so everybody could access that. And you can plug in the patient's age, sex, and a cup angle, Reaser, and it gives you the high risk of progression. In this case, I always pick now throughout the slides a 10-year-old female with 30 cup degrees who's not growing tall yet, and you can see the high potential risk of progression for these curvatures. So guidelines are made and based on consensus for bracing and scoliosis-specific physiotherapy treatments by many leading societies. I'm going to mention 3, the SRS, the SOSORT, and Columbia University established a best practice guideline as well. As well as guidelines and indications for bracing for immature patients are 20 to 40 cup degrees, and you can see a little bit more mature patients, 30 to 40 cup degrees. And there are also gray zones and observation zones as well. And the SOSORT, this is an international society on scoliosis, orthopedic, and rehabilitation treatment, and a multidisciplinary group produced SOSORT guidelines, and the latest in 2016, when I was fortunate to take part of it. And you can see the cup angles on the top, and of course the bone maturity on the side, and indicating minimum and maximum treatment based on the cup angle and age of the patient. Also could be producing a calculation and come up with this graph. It's also indicating the treatment which is recommended according to the SOSORT guidelines. So once you have the cup angle, the Reaser sign, and a chronological age, you can calculate the risk of progression, and you can see what type of treatment might be recommended for that individual. And since 2013, since the BRACE study was published, we can say in confidence that bracing prevents the need of surgery, according to Dr. Weinstein. And you can also see the bracing indications with all the leading guidelines. Usually it's about the moderate curves, which are needing bracing, and the BRACE study indicates success if the cup angle the progression finishes below 50 degrees. We like the children to finish much lower degree than that, to be having an easier, manageable condition for the future. And they recommend more than 13 hours of brace wearing, as well as the SOSORT guidelines recommending up to 18 and higher hours of brace wearing for the immature children or teens population. And Columbia brought together over 30 experts from around the world to create the best practice guidelines for bracing in adolescent idiopathic scoliosis in 2019. They explored when to brace, when not to brace, the brace wearing hours, monitoring, compliance, radiographs, the dose, and the brace timing, and also discussed the scoliosis-specific physiotherapy added to the standard of care when it's available or where is available. And you can download this AIS bracing checklist, which is very helpful to use in your practices. Altogether, we can look at the education component of the scoliosis, raising more awareness and educate families. And when we get to the detection stage with the screening programs, and if you find smaller curves below 15 cup degrees, those patients can engage in posture education and exercises. Once between 15 and 25 degrees, it's a pre-bracing period. We recommend scoliosis-specific physiotherapy. And then at 25 to 45 cup degrees, as most societies recommending bracing treatment added to the standard of care, and over 50 cup degrees are surgical indications. This is the ideal patient screened out at an early stage. You can see these curvatures are 20 to 25 cup degrees, 3 different patients. This has been presented, this case series, internationally. And between the 2 X-rays, which are standard of care here, every 6 months they're following with the standing X-ray in a children's hospital, the children who are diagnosed with scoliosis. Between 6 months, they engaged in scoliosis-specific physiotherapy, and you can see the end result here with all 3 cases are quite straight. So these children are looking ahead to go through the growth period with a less likely progression, and this would be the ideal standard of care for the future once the early diagnosis established based on screening. And a little bit of history about scoliosis-specific physiotherapy. It has been around for a very long time. Leon method is over 200 years old, so as other German method, the clap, the Schroth as well. And Min Mehta established a side shift method in United Kingdom. Italy, they established CIAS. In Spain, BSBTS, and Poland has FITS and other programs. So it is important to understand that all these scoliosis-specific physiotherapies have some things in common, and I'm going to show you that as well. And in United States and Canada, we established the International SSO Schroth teaching facility, as well as courses and postgraduate education for all the physiotherapists around the world. This publication, which was published on scoliosis-specific physiotherapy back in 2017, looking at a few methods which have great evidence. Since then, we have even more RCTs of different scoliosis-specific physiotherapy methods, and this could be viewed on a spinal scoliosis and spinal disorder journal, free open access if you're interested in learning more on scoliosis-specific physiotherapies. They all have common indicators, common treatments, which they establish. It's auto self-elongation or auto correction in 3 dimensions of the scoliosis posture, and stabilization in a best possible position, and theoretical information to the patient, education on active daily living activities, sitting, sleeping, standing, walking, and restoration of the sagittal alignment, which is very important. These are based on the SOSORT guidelines. And Dr. Michael Vitale, the Chief Pediatric and Orthopedics and Morgan Stanley Children's Hospital, also stated that if you look at the critical evidence in the body of the literature, there is evidence that when properly done in the right situation with the right therapist, the right patient, Schroth can change the chance of curve progression. So this obviously based on hugely the compliance of the patient and the monitoring of the curvature. And just a little bit about the Schroth method, which is more and more popular around the world, as well as in North America. A Schroth method was coming to us from Germany, from Katharina Schroth and her daughter, Christa Leonard Schroth, established a physiotherapy method, and it's even up to date, practiced in a huge institute, Asclepios Clinic now, with anytime stepping in there, 200 patients doing physiotherapy exercises in a group setting. And it was further improved, and other methods like the best practice method developed by Dr. Hans Rudolph, the son of Christa Leonard Schroth as well. So back then, they established this clinic outdoors in the fresh air with very severe curvatures, treating the patients when there were no surgeries or even bracing easily obtainable. And in 2007, the three-dimensional treatment for scoliosis book was published by Christa Leonard Schroth, and it was translated to English when it was really reaching outside from Germany and reaching with the method many different countries. In 2008, I was starting to learning the method with her. And in 2009, Dr. Boachi and Dr. Berdyshevsky established the first Schroth method physiotherapy services in a hospital special surgery, and later in Colombia under the care of Dr. Vitale. So that's when it really hit North America. You can also look up courses and find Schroth physiotherapists trained around the world on an original Schroth website. And you can see how this orthopedic breathing, rotational angular breathing, started with very severe curvatures back then to open up the concavities and creating isometric tensions around the prominences to improve the air entry and reduce the scoliotic posture. You can see how the breathing function is so asymmetric when the patient's having scoliosis. I'm not sure if this will work, but we can try. Doesn't look like it wants to work, but you can see the asymmetric thorax as well as the asymmetric lung function. One is a stretched lung, one is a collapsed lung. And back then, during exercise, they taken X-rays, which means that during the exercises, we can see the reduction of the cub angle and improvement of all the three different angles of the thoracic, the lumbar, and the lumbosacral angles during the exercises. These days, the University of Alberta doing similar studies with ultrasound imaging showing that during exercises, almost most of the conditions are reducing up to 50% in the cub angle, and we hope to build the muscle brace around them to maintain the improvement of the postural component of the scoliosis. And we're looking at the vicious cycle of Ian Stokes to reduce the asymmetric loading, to reduce the patient's asymmetric posture. And you can see that Lewis in 1877 already developed a scoliosis model with the elastics pulling to the side. And if there's any axial compression, any pressure coming from the top, it is increasing and producing scoliosis. So we are trying to have the reversal of these effects, making the patient axial elongate and reverse the asymmetric loading. How does it work on a patient? You can see an important curvature here. This patient was not braced and was doing scoliosis-specific physiotherapy during the pandemic and Schroth method-based exercises. And you can enlarge it here. You can see the wedge disc and the beginning of the scoliosis progression development in a reserve 0, very immature teenager. While when they went back for a checkup, 6 months later, you can see the wedging disappeared and the condition improved posturally very well and no needing for brace treatment. So this is an ideal case without, which is avoiding the brace treatment in this case. But let's look at other way of looking at the asymmetric postures. Scoliosis is a combination of some structural deformities of the disc and the bone, as well as a postural component. So you can see two x-rays here. One is before and the other one is after have been treated with scoliosis-specific physiotherapy. And if you have these two cases in front of you and you're a spinal surgeon, you would be recommending at 50 cup degree spinal fusion surgery, and at 35 degree, you would be recommending bracing treatment for a still growing a teenager. So you can see that if we take away the postural component and we left with the structural component, often is a lower Cobb angle than the postural component combined. PSSC exercise is based on curve types and can be modified for age and ability. And for example, the Schroth method-based physiotherapy is not a very simple exercise routine. It needs the very intensive patient education and engagement, and individualized correction requires the patient cognitive, emotional, and physical ability to learn and perform curve-specific exercises independently at home, and often a parental support needed for the teenagers, provided by certified scoliosis-specific certified physiotherapist. And it is important that to be tailored to the sagittal profile of the patient. So we provide these up-to-date SSOS courses. You can send your team member to these courses we teach worldwide to add a very well-trained scoliosis-specific physiotherapy to your physiotherapist to your treatment team. And this is in progress. This is how the patients come in with the flat back, more like inverted back here, with a scoliotic posture, with the convex and the concave side asymmetry. And we teach them how to get taller, axial elongate, how to manage the sagittal normalization of the posture, how to deflect, derotate the curve, and inflate the concave area with the correctional breathing and stabilization, providing strengthening. These are original drawings from Crystal Leonard Schroth showing the muscular asymmetries, and I hope this might be working to show you, but it doesn't want to work, show you how this patient is improving her postural asymmetric postural scoliotic posture during the exercises. Even though we tried, it really doesn't work. So cannot really see this. Maybe we can add it to the recording. And we are teaching patients in a group setting. It's much more beneficial and motivating for the children and teens to use the exercises and learn the exercises in a group setting at the clinic or even in the online groups. And the braces come off before the exercises. So all the braces are lined up here on the bench and they're ready to do their group exercises. And we also treat the hyperkyphosis, the juvenile hyperkyphosis cases. In this case, the teen had both hyperkyphosis and a mild scoliosis, and going back for the 6-month checkup, had improved the hyperkyphotic posture as well as the scoliosis. So these are patients who are early diagnosed and treated on time. And some publications and references for you to see how the scoliosis-specific exercises reducing the needing of bracing using different scoliosis-specific physiotherapy methods. Let's move on into Canadian Douglas Hedden, the surgeon who specialized in scoliosis treatment in Canada here, stated that results of our study strengthens the emerging positive evidence on the effect of the Schroth on the cup angle changes of AIS. This is Canadian research, and there are a lot more research available for you on Schroth method and many randomized controlled trials established to improve the posture, to improve the cardiorespiratory dysfunction, and improve the quality of life, reducing pain of these patients. Postpone or avoid surgery might be an ideal goal. And you can see the deformity, how it affects the lungs, and we'll talk about it a little bit later. And let's go by the next segment, looking at the groups which have the 20 to 40 cup degrees and the brace indications, or more mature patients, 30 to 40 cup degree brace indications according to the SRS guidelines. And since the brace study is published by Dr. Weinstein and Dolan, we know now the braces are very effective for teenagers in halting progression. We check the in-brace posture. We teach the patients how to manage the bracing and everyday and full-time activities. And we also teach them in-brace breathing function, where we are facilitating to open the concavity and use the more collapsed ribs for opening up and allowing air entry in a concavity and breathing in a better way. So this is another great study from Hong Kong showing the effectiveness of Schroth physiotherapy and bracing combined. And you can see the different control groups here that only 21% only 17% patient in a Schroth group are the ones who did not improve, okay? Once we go through the bracing and the scoliosis-specific physiotherapy combined treatment, this is one of my case. You can see this X-ray report down here stated that previously 47 cup degree reduced to 36, or previous 44 cup degree reduced to 30 cup degrees. This patient has a lot better chance in life to live a healthy life without needing the surgical intervention. And the most interesting part is the rotational component, which is also decreased during the treatment and maintained 2 years afterwards. This is from the Scottish Rite Children's Hospital of Texas. A night brace combined with Schroth physiotherapy also shows great improvement, and the progression reduced in the part-time braced patients with Schroth physiotherapy. And I'm proud to say this is one of my students who's doing the therapy here. And Schroth physiotherapy added to bracing treatment. You have a randomized controlled trial showing here the recommendations for also not just scoliosis, but hyperkyphosis. And the brace compliance is key. We can see that in brace study, the hours, the less hours the patients are wearing the bracing, the less successful they are. So more progression will happen if the patients are wearing the brace less hours. So more hours are recommended, 20 to 23 hours of bracing time, reducing the chance of progression. Brace wearing, again, with all the guidelines combined, brace weaning, we try to encourage the weaning gradually at reserve 4. And the 2 studies are recommending here, reserve 4 or Sanders 8, to start the brace weaning. Bracing is different in North America and other parts of the world. Many European countries are bracing not just full-time, but throughout activities. In North America, we allow the teenagers to take off the brace during their physical activities and put the brace back on after they did their sports and physical activities. Not all braces are the same. You can see a pretty poor construction of this brace. So you have to check the brace construction. You can see that this curvature did not make any difference in the brace or frontal and the dorsal pictures here. And you have to check the quality of the brace. It's not the name, but the quality, how well the patient is established in a frontal and a sagittal plane while wearing the brace. So let's discuss why Schroth therapy and not just any core strengthening exercise. You can see this great randomized control trial from Turkey showing the benefits of specific exercises. And this is a picture for you, since probably we'll have some questions about why not do yoga or other fitness exercises for scoliosis. It's not what you do, but how you do it. You can see this severe curve doing side plank exercise and not changing much of the curvature, while when we put her in a Schroth position and activate the concave side, you can see a great change in this very severe curvature. And I like to show this study. This is a high level of soccer player, and doing her training, side planks and planks as a part of their warm-up in a soccer practice. And when they wear their shirts and t-shirts, they don't see how these curvatures are managed during these exercises. So we teach them how to do it correctly, how to manage the sagittal profile correctly during their training. And only in Crystal Leonard Schroth's book, you can find recommendations what not to do. What not to do in terms of movements. These extreme movements are promoting scoliosis curve progression into more extension, more rotation, more side flexion. So this is a recommendation from Crystal Leonard Schroth. And we know that the relative anterior spinal overgrowth happen with scoliotic curvature, especially more aggressively in an adolescent population, even some severe way of inverted back, as you can see here. And we know that we should not encourage that with our exercises. So some of the exercises which are creating more extension to an already extended spine is clearly not beneficial. Sleeping position, we educate the patients on ADL and sleeping position. Ideally, in this case, in a major lumbar curve, not to sleep on the convex side because that will increase the potential of progression all night. But let's say in a concave side, we can have the gravity affecting the curve, the pelvis is normalized, and ideally, the patient sleeps in this position. We also educate them on a sagittal profile during their activities, correcting posture during playing guitar, having more lordosis, having more postural symmetry, playing other instruments, very important. And it's also important to find and seek out the best trained physiotherapists in your region and add them to the treatment team to educate your patients, because this is not a 30-minute session. This is a full-time care for scoliosis patients, and education of the patient is critical, and we have to form a team and follow all the great guidelines from the leading societies and best practice as well. So let's look at the gray zone. What do we do with the patients in the gray zone? According to the Scoliosis Research Society, cup angle between 40 and 50 degrees, really heading for surgery, but they're kind of waiting and observing that curvature. So while waiting and observing, why not make a little bit of improvement of these curvatures? This patient was on a wait list here. We have a 2-year wait list for spinal fusion surgery back then. Hopefully it improved since then. During that year, first year, the patient obtained a 3-dimensional Rigo Chanel brace and engaged in scoliosis-specific physiotherapy. Starting cup angle was 56 degrees, and 1 year later, 42 degrees. She's off the surgical list, and you can see the huge improvement of the posture, how strong this patient is in a corrective way. You can also see some compressions from the bracing, compliant patient engaged in the full treatment was 2.5 years in his case, and she's still not needing any surgery. She has established a 42-degree cup degree out of brace of 2 years. So those are great successful cases. And when fusion is refused, what do we do with this 70 cup degree patient who does not want to have a surgical intervention? We have to make sure that looking after eliminating pain, preventing potential progression into adulthood, preventing disability, and definitely work on the vital capacity to improve the lung function, very critical, and aesthetics. So these are patients who are in the gray zone. They are also engaged in a group physiotherapy and maintaining the regular physiotherapy that well. This case has been studied, published, and this is a very severe curvature who also important to know that had a childhood surgery on a thorax, which potentially added progression or development of her scoliosis, and again also engaged in scoliosis-specific physiotherapy. This is an interesting case, not just because we had the frontal and a sagittal plane view before starting treatment, but also after the surgeries, surgeons suggested just engage in regular activities. And so the patient became active, did some more taekwondo and other sports, and increased the rib hump, increased the scoliosis. She did not want to wear a brace, so she engaged in scoliosis-specific physiotherapy, Schroth method, 2 hours a day, very consistent, compliant. The surgeon gave her another 6 months afterwards as she started to reduce her rib hump as well as the cup angle, and she finished with a very good cup angle. This is another case which you can see if we leave this patient in this scoliotic posture long enough. Unfortunately, the other case needed surgery. This patient had a very overcorrective brace. You can see this still a flexible spine, both were, but this patient did the bracing, and for some miracle reason, she actually straightened her spine with scoliosis-specific exercises as well as the brace indication, compliance with the brace. And this may not be a very typical AIS, mostly at late onset, but you can see the scoliotic posture, you can see her brace, as well as the postural component of the scoliosis. And full-time bracing combined with Schroth physiotherapy in an earlier childhood in GIS cases. In this case, we used the brace for 10 years. We used the Rigo Chanel type of brace. And this case, we won't have time to make it very detailed, but great improvement for that patient, avoiding multiple growing rod surgeries, as well as final fusion surgery. She ended up with 25 cup degree. Now she's in university and still staying at 25 cup degree at the end of the treatment. So we encourage group physiotherapy and individual Schroth physiotherapy added to the standard of care for the patients. And let's see what happens with post-surgical patients. When patients had surgery, and in this case, a selective spinal fusion, very straight spine, but after fusion, the thorax still not balanced and normalized. She engaged in scoliosis-specific physiotherapy, not just to improve her aesthetic, but mostly to prevent the further progression of the lumbar compensatory curve, which was not just halted, but reduced 10 degrees. It's also a great poster presentation in an international SOSORT conference. What happens with failed VBT surgery when a cord breaks? Some patients are hesitant to engage in the spinal fusion immediately. So they engage in scoliosis-specific physiotherapy. These are young patients who are still very flexible. Now they not just have to manage their muscles, but the hardware. So that's also a great result for this patient. And this is a Scoliosis Research Society conference by Dr. Gross, who have been demonstrated that 1-year physiotherapy for this post-surgical hyperkyphotic Sherman patient improved the posture post-surgical and not needing a reversion surgery for this case. So the main take-home message is really to try to see how the patients can improve their scoliotic posture, how we can reshape the thorax to reduce the potential increase of the patient's cup angle. And you can see, if you could see, but I don't think you can see, but you can see that during treatment here, this very rotated early onset scoliosis patient is working on reduction of the rib hump and opening the concavity to normalize the posture. So going into early onset scoliosis, which is a lot more severe condition, it's always a great risk of these patients of fast progression and severe condition to develop mostly left curvatures you can find in an earlier age group. And early onset scoliosis diagnosis includes not just idiopathic, but neuromuscular scoliosis, congenital and syndromic scoliosis as well. So these curvatures are faster progressive. Neurofibromatosis also often develop severe scoliosis curvatures, and this is a neuromuscular scoliosis case doing scoliosis-specific physiotherapy as well. I know we are getting close to the end of my time, so I'm trying to jump ahead a little bit, making sure that we double check the hypermobility of our patients, because that is also very commonly an issue of the patients of connective tissue disorder. This is an Ehlers-Danlos syndrome patient who is 6 years old. The bracing is not really a good quality brace, and you can see the thorax very underdeveloped. And unfortunately, he's now looking at going into a growing rod surgery very shortly. And we need to work on the thorax and the rib cage expansion for these patients. We want to avoid these very severe conditions which can develop with early onset scoliosis. And unfortunately, with again early detection, these patients could be very well managed. And the main treatment for these patients really would be the casting treatment, as well as later on managing them with the bracing ideally. But we also have to look after the lungs, the lung deformity inside the rib cage deformity is a huge problem, and these children unfortunately develop many complications, and the mortality rate is 3 times more due to pulmonary hypertension than the AIS population. They need to be active, they need to do exercise, they need to improve their ventilation. Sometimes they're losing not just the lung function, but also their BMI is extremely low because they are using all their energy to breathe and stay ventilated. So I'm going to stop here shortly because I know you have a lot of questions. And I'm happy to answer any of the questions you might have. And I really appreciate the interest of your colleagues in scoliosis-specific physiotherapy and management conservatively of these conditions. And we hope more and more surgeons will take initiative to add a very well-trained scoliosis-specific physiotherapist and orthotists to the team to offer non-surgical treatment as well.
Wow, what a beautiful talk it was, Dr. Andrea. It was really beautiful, fantastic. Like my phone is full of messages. Really loved it. The way you explained all the bracing versus Schroth exercises, how prevention of progression. uh, Really amazing work. And over like
Thank
last
you.
4 decades, you've been doing that, and we really salute your amazing work. So just a few questions to you. Like we already over short time, but we'll like to know uh, for the young adults, like age 18 to 40, what are your thoughts on with scoliosis patients between 38 degrees to 50 degrees, not the surgical candidates more than 50 degrees. Okay, what's the uh, kind of short or physiotherapy protocols you suggest or advise to these patients? So I'm repeating the criteria: age group 18 to 40, and Cobb's angle less than 45.
Okay, thank you. So it's all going to be depending on their bone maturity staging. If they're already reserve 4 or Sanders 8 and up, they will not be braced according to the international guidelines. So all that remains for them to do is cause-specific physiotherapy. We teach them postural corrections, home exercise program. We see them initially once a week for an hour here at the clinic. And once they're independently managing their home exercises, they can join the group exercises here to stay motivated, to stay compliant until they can look after themselves. They have to manage this curvature for the rest of their lives. Unfortunately, 30-degree Cobb angles and higher do have some progression into adulthood, maybe less than 1 degree, but it is something which they can avoid if they're managing to reduce the asymmetric loading, if they're managing the proper orthopedic breathing and staying active. We always encourage them to stay active, look after bone health, vitamin D, jogging, going to the gym, but making sure that they keep in mind the asymmetric trunk they have and use the equipment in the best possible 3D correction for their posture. So they have to stay active. They're still building the bone density until age 30, 35. So we need to have these patients healthy and active for a very long time.
Thank you very much. Just like one quick question. The answer might be a little long. The software professionals who have a sedentary lifestyle, who sit long hours for their work, like 6, 8 hours, 10 hours in a day. If you can give a quick your experience thought, what things to do when they have the sedentary lifestyle, sitting laptop jobs, people.
Sure. That's probably majority of the world these days.
Yes.
Sitting is the second smoking these days, so it is very hard to maintain a good sagittal profile. You must use a nice lumbar support or have a built-in lumbar support in your chair, because once the lordosis is lost, the back pain gonna come. So very important to have a proper sitting arrangement, maybe an ergonomic assessment, having your laptop in eye level, make the tables higher, just to make sure that you're not looking down, not rounding your posture. Ideally, get up every 15 minutes and stretch and move around, walk around a little bit, or use a sit-stand desk, which is available. If you don't have one, you can just get a big box and put your computer on it to stand more than sit. Standing will more physiological for your sagittal profile, your lumbar lordosis maintained, and also it's against gravity. You're not going to collapse into your posture. So I recommend sit-stand options, more standing than sitting, as well as supporting the lumbar curvature, making sure that the head is not going forward, supporting the arms and get up. Get up and stay active right after work.
Thank you. Really beautiful explanation, and we really loved it. Uh, really phenomenal work you've been doing, and we wish you all the best. Thank you very much.
Thank you very much for
And
having me, and I'm available for questions and hope that everyone will add the scoliosis-specific physiotherapy to their standard of care for the children and teens. And thank you for all the work you're doing in terms of raising awareness and educating professionals around the world. So it was my pleasure to take part on this program.
thank you. Just to add, Dr. Andrea Lebel has joined our Spine TV groups, and she will be posting contents for us about the awareness, and she'll be the editor for a month for all of us. So join the Spine TV groups, and we are looking forward to all of you. Happy Independence Day, India, and take care, everyone.
Take care. Bye-bye, everyone.
So we can go offline, Rishi sir.